Great. Welcome, everyone, and thanks so much for joining us. This is Amy Lawrence. I'm a program officer here at Sierra Health Foundation in the center, and we're so glad you're here with us today. Uh, we wanted to take a moment and share the data brief prepared by our colleagues at UCLA. I know many of you have probably had a chance to review this, but we really wanted to just take a moment to reflect on the incredible work and impact of this program. And uh, we also really wanted to have a chance to share it more in depth with you. So thanks again for joining us today. As you heard, this webinar is being recorded, so you can take a look back at it or share it with any colleagues that weren't able to be here today. With that, I would like to introduce Kendall Darfler from UCLA. Kendall.
Hi, thank you so much for having me. I am really looking forward to talking through this with you all today. My name is Kendall Darfler. I am the co-principal investigator of UCLA's outcomes analysis of the State Opioid Response Program, or SOR, overall. And one of those programs is the Low Barrier Treatment at SSP's project, which you all are obviously very familiar with. My colleague Kira Jeter, who is our evaluation manager, was going to be joining me today, but had a family emergency. But at the end, I'll have both of our contact information if you want to chat with either of us further about anything that you hear today. And so I'm really going to be summarizing the data brief. So if you've read it, you'll know a lot of this already. There are a few little additional pieces of information that I'll share with you. And then at the end, I really just want to open up a few things for discussion. The data that we're looking at in this particular brief really come from our quantitative data portal, where we get quarterly reports of the data that you all send to the center. And those data, while super informative and have a lot of really great takeaways to share with you all, are kind of the tip of the iceberg. And we just would love to hear from you all. Some of the practices and things that you're doing that are working so well, because kind of the key takeaway here is that they are working so well. So with all of that said, I'm going to go ahead and dive into it. I'm sure many of you know this already, but I just wanted to kind of recap that the goal of this project is to support the integration of treatment and harm reduction services at SSPs, as well as additional services, so harm reduction, case management, peer support, all at SSPs. The funding source comes from ultimately the federal government, the State Opioid Response Program, and is administered at the state level from the Department of Healthcare Services, and then to you all via the center. And so our role at UCLA is to evaluate the SOR project overall. We started collecting data for this program in April of 2021, which was the first round of funding, which I know some of you all participated in both the first and second round. And then we have the data from the most recent SOR 3, we're calling it, round of funding. And we kind of will show on the timeline where the project breaks out into those two different funding rounds. And the metrics that we are collecting data on are kind of common across all of or many of the SOR programs with like a direct service component. And the main focus is on increasing access to treatment. So individuals starting mood by medication type, so buprenorphine, methadone, and extended release naltrexone or Vivitrol. Individuals starting any form of treatment for stimulant use, including contingency management, which that's one of the real highlights of this program. And then individuals receiving additional services. Demographics is really important. We also collect the number of staff and providers, and some data on trainings held and attendees at those trainings, which the training data are not included in this brief. But I'm going to go ahead and dive into some of these main outcomes from these top other key metrics that we discussed in the brief. So again, key metrics are around treatment expansion for the SOR programs. So over 7,000, almost 8,000 new individuals have started MOOD via this program. Most of those folks have started treatment with buprenorphine. And then almost as many have started treatment for stimulant use, which is really a fantastic highlight of this program. And a third of those have started contingency management. So this is really, really unique. A lot of projects have tried to integrate treatment for stimulant use and have thought about using incentives and contingency management and haven't totally gotten there yet. So this is kind of one of the things that we think is like a shining example of what this program is achieving. And we kind of want to learn a little bit more about how like the harm reduction approach and how SSPs might be approaching stimulant use and providing incentives and contingency management in ways that other folks could really learn from. I think that there is quite a bit of stigma around contingency management. And I think that, you know, SSPs are really particularly well suited to address stimulant use because of the central philosophy of harm reduction and really meeting people where they're at. So that's going to be kind of one of the questions that I would love to hear from you all at the end. But moving along into some more of the data that was in the brief, the number of patients starting MOOD each month has certainly grown since the start of the program. You can see those first, 6 months, the numbers were much, much lower and they grew over time. I do want to make the key distinguishing mark that between SOR2 and SOR3, the changeover happened at this dotted line. Some sites shifted over and stopped continuing, and there were a lot of new sites added. So we're not really comparing the same sites to the same sites in these two time periods, but we can just look at the program overall. And really, I think what we're seeing here is under the latest round of funding, SOR3, numbers have started to kind of stabilize a little bit, which is good. There has been in the number of patients starting buprenorphine, particularly this darker blue line, a bit of a drop off in the last 3 or 4 months of data collection that we have. So that would be October, November, and December of 2023. We typically see some numbers drop during the winter, during the holiday season. But if anybody has thoughts about something else that might have happened during that time that you want to share, we would love to learn from you all what that could potentially be. But with that said, the numbers of individuals starting treatment kind of per site are still very high, especially compared to a lot of other programs. And this is great. So as long as we don't see the numbers continuing to drop, I think a little bit of variation is to be expected. And then the numbers of folks starting methadone and Vivitrol are lower, kind of as expected. Obviously, the focus here has been on buprenorphine a bit more. And we see a fairly similar story for the number of folks starting treatment for stimulant use each month. This is, again, kind of any form of treatment. It's stabilized a bit more over the course of the latest round of funding, SOR3, with actually quite a bit of growth. You can see we were in kind of the mid hundreds, and now we're up into the high to mid 200s of numbers of folks starting treatment each month. So quite a bit of growth over the last 2 years of The grant, again, slight dip in the most recent months, but really this has been a wonderful piece of this program. I'll go ahead and look at the next slide here. You can really see the point of comparison here. First, we have the number of folks who are currently in treatment. This is kind of as of December 2023, right? Like the end of that last quarter. A little over 4,000 in treatment for opioid use only, 1,375 for stimulant use only, and then 3,300 for both opioid and stimulant use. And this is really kind of amazing. So the average number of patients currently in treatment for stimulant use alone is 49 per site. It's a slight difference from what was in the brief because we actually found out about an additional site, but still 49 is really great. And then for both opioid and stimulant use together, that last blue bar is 118 on average per site. That's far higher than any other SOR project. So again, this is a really, really wonderful outcome that we're really excited about, and would love to hear your perspectives on really what's working and how you're reaching so many folks who have both opioid and stimulant use. And then some notes on the kind of additional services, right? So the treatment numbers are kind of the key metric that we collect, but we also collect data on the number of folks receiving harm reduction, peer delivered, and other services. So in the most recent 6 months, which is kind of the biggest batch of data for this time period, almost 23,000 unique individuals, meaning like not double counting anybody, received harm reduction services via this program. So that's wonderful. Obviously, much higher than any of the other SOR projects because of the focus on harm reduction. And then over 7,000 received peer support. There are 119 peers working in the sites. That's an average of 4.25 per site. And again, and I think this is to be expected, this is the largest number of peers per site across any project, and the largest number of folks getting peer delivered services, which is a really, really key area of expansion that DHCS is super interested in. I do think this is totally makes sense given that SSPs are already peer-led, but really just speaks to the importance of this this program and the SSP as a location of low barrier treatment. And then almost 9,000 individuals received any form of recovery support, and almost 8,000 received case management services. So really, really fantastic numbers just across the board. And then this is another really key highlight of this project. The SSP project's patient population included one of the largest proportions of people of color across all of the SOR projects. And to be kind of more specific about that, this project has the greatest proportions of Black, Asian American, and Native Hawaiian and Pacific Islander people of any project. So those three groups are definitely much more represented here than we're seeing elsewhere. And one of the highest proportions of Indigenous people as well. And this is one of the most important outcomes of this project, because we're really in a time where not only are overdose death rates rising most rapidly for Black and Indigenous California residents, but we're also seeing kind of across the board that those communities have less and less access to mood and other treatment services over time, especially in the wake of the pandemic. every SOR project besides this one has had drops in the proportion of Black patients served during the last round of funding. And for the SSP project, the proportion has actually grown. And we talked a little bit, you could see in the brief some comments that the center provided about what's really working here. And based on what we talked about, we really do think it's the harm reduction approach of centering people who use drugs and like genuinely meeting people where they are in the community. But again, would love to hear from you all what kind of practices and approaches that you think might be making the biggest impact on reaching communities of color. And I think this is something we would love to do a follow-up brief on with kind of some more like qualitative information from you all. And DHCS is super interested to learn really what works as well, to kind of share that with other folks and other projects. So we'd love to hear your perspectives on this. The last kind of bit of the brief is just talking about implementation challenges and successes. So some of the challenges that the center highlighted for us are just like the broader societal challenges of like stigma toward harm reduction and SSPs kind of in the community, addressing the changing drug landscape. So how are we addressing the presence of fentanyl and xylazine? They really highlighted that sweeps of unhoused communities make it extremely difficult for patients served by the SSP projects to access treatment services, which is really unfortunate and is something we think it's really important for DHCS to be aware of. And then staffing. I think everybody is having staffing challenges right now, especially but at the kind of more grassroots level where there might be one or two people wearing multiple hats. It's a lot to manage. But despite all of that, again, this program has been incredibly successful. You know, we think some of the successes come from truly meeting people where they're at in the community, and doing things that are kind of above and beyond, right? Like driving people to appointments, driving people to the pharmacy to pick up their medication, that other types of treatment settings aren't doing or might not be equipped to do at this point. And then the center also highlighted, you know, providing lower barrier funding with less kind of reporting requirements and being able to provide some of the funds up front so that you all are not like fronting the cost of things is really, really important for a project like this. So that's kind of the overview of what was in the brief. I was trying to be quite brief about that because I really want to open up a dialogue to hear from you all, you know, what you're thinking about these data, about what you saw in the brief or heard in this presentation today. And really like from your perspective, what are some of the practices or approaches or, you know, just outlooks that SSPs use that improve access to treatment and other services, particularly with regard to reaching people who use stimulants, providing contingency management or incentives, and reaching communities of color. And I kind of like, I suspect that we know some of the answers to these things, like what are the cornerstones of like the harm reduction philosophy that you all find to be really important to truly creating like a low barrier or low threshold approach. And then also just some of the barriers and facilitators to integrating treatment and harm reduction services, especially things like peer delivered services. So I'm gonna leave this slide up and I would love to hear if any of you all have thoughts on this.
Thanks so much, Kendall. We definitely invite people to drop comments into the chat, or if you want to raise your hand, we can also unmute you so that you can comment verbally.
I'm also seeing a comment from Matt in the chat about when we say site, yes, we mean per participating organization. I think we get so used to in the research world, like talking about sites. But yeah, it doesn't mean like one specific physical location. It's per program that's participating. Thank you.
Matt, I think you can go ahead.
Hey there, just to get the wheels greased on uh, talking a little bit, I'd flag a couple things that really came from when some of us were designing this program back in around 2020. Two things I'd really highlight as being crucial to the way that these services have been successful. One is that the whole idea for this program really directly came from feedback that a bunch of us were getting from harm reduction participants. And so that notion of paying attention to what people are actually asking for, what they're not asking for, and having a lot of dialogue with folks about that directly informed the whole genesis of this program. And a lot of that happened, I mean, some of you may remember back around 2017, 2018, CDPH and National Harm Reduction Coalition did a series of listening sessions around harm reduction all over the state, and everywhere that those events went, there were meetings specifically with harm reduction participants. And actually, access to medication for opioid use disorder, and particularly buprenorphine at that time, was the number one thing that people identified as a missing service, and something that they thought that their harm reduction providers could do in a way that was better for them than other settings where they were getting that service. So that was kind of the original idea. And when the regulations changed, during the early COVID period, there were already harm reduction groups that were doing this. I mean, I distinctly remember Hatcher in Humboldt County was a really early adopter of telehealth-based buprenorphine access. That's how this got rolling. And second, the way that this is designed is that most of the funding is really for wraparound services that are directly meant to get at that low barrier notion. So uh, clinical, I mean, there are, these grants are also in part, in some cases, paying for clinicians' time and medication for people who have gaps in insurance coverage. But for the most part, it's really that kind of like pure support, transportation assistance, basic needs assistance, that ability to really like connect with people wherever and whenever they are wanting to do something around this is part of the harm reduction ethos, and something that was really, again, intentionally baked into the program.
Thank you, Matt. Yeah, I really appreciate you sharing that perspective of how this kind of came to be. And I'm seeing someone type something out in the chat. If it's okay with you, I'm going to kind of read it aloud. Wesley Saver saying, I just want to give a shout out to anyone who is thinking about contingency management, which is an excellent intervention for psychostimulant users. And HR 360 has a contingency management program as part of our outpatient program services. It has really been successful with our participants, especially justice-involved participants. I cannot recommend this highly enough. The stories from participants about how they use the rewards that they receive were so great. Thank you, Wesley. I don't know if you have anything that you want to add, but that's super helpful. I think providing contingency management is something that a lot of the other programs have kind of shied away from. And so hearing kind of what's working and how well that's going is so wonderful to know. Oh, Paul Harkin. And I see you're in the chat bubble now. Do you want to unmute?
Hey there, can you hear me now?
Yes.
Okay, cool. Yeah, well, I know that the San Francisco AIDS Foundation has also been doing contingency management for a long time, and that's also been highly successful. We got because with the change in the law that allowed it, because previously it was kind of banned, as seen as as a kind of, it could be easily used in a corrupt way to manipulate patient counts by giving them free money, so to speak. So the law got changed to allow it because it basically is the only evidence-based intervention for psychostimulant users. So it's basically methamphetamine and cocaine. You can still use other drugs. You're getting tested only for stimulants. So, and people basically, they come in weekly and they have to do a urinalysis. And then if it's negative for stimulants, they get incentivized. And it's a sort of, it's called a prize. And it's basically rewarding good behavior versus punishing bad behavior, right? So uh, people have, people really respond to it. It's apparently, there's sort of neural pathways that kind of get into that get sort of into the game thing of like, yeah, I can do this. And just the way it works, it's like goes way back to like 60s sort of psychological theories and stuff about rewarding good behavior. So it's pretty well grounded. There's been millions of data from the veterans because they've been using it for a long, long time, but it was kind of prohibited because of how it could be corrupted. So nobody else got a chance to try it. We've only had it for just about a year now, and it's like we had amazing success, like really high. There's going to be a data presentation, I think, at the SUD conference in Long Beach in August. But from just looking at preliminaries, really effective with BIPOC populations, which is great because they're still underserved in a lot of the interventions. There's really nothing out there for stimulant users. So this is something I think once people get a handle on it, it could really explode, And like you were saying earlier, that the weird controversy is often from like super privileged people who hate the idea that people get paid to do the right thing. So it's a very kind of moral even though it's cost effective in the sense that if you add up like the benefits where there'll be less less hospital visits for people who are having like heart attack, panic attacks, sort of psychostimulant overdose, etc. People who can maintain their employment because they're part of this program. It's just the stories have been amazing. Like people bought their children gifts because a lot of them bank it and don't take it till the end, so they get a lump sum. And of course, the critics would say, "Oh, they're going to spend that on drugs," but people buy things like tools and build their kids' beds, or some guy bought him and his dad like new suits and like sent a photograph to everybody of the two of them wearing their new suits. And like people, somebody gave it to their ex-partner to get just like lots of amazing like things that they like to share, about and just people feeling good about it. Even somebody was talking about how it was really a change in their mindset to piss in a cup for a benefit versus a punishment, which was, unfortunately that's still a part of it because I think personally I'm against urinalysis, but they need it in this. So anyway, just I think you just need a private space. You have to do the counseling session. So programs might be that have that kind of, you've got an office where you maybe do HIV testing or Hep C testing you can use for counseling. It's like there's a lot of kind of strict things that come with it, like because of the way the state's funding it right now. But as long as you meet those criteria, you can do it. And I think just when I think about certainly in San Francisco, the number of stimulant users that are not getting access to this because it's very limited in the way it's been offered currently. It'd be great if all the other SSPs here were able to do it, along with AIDS Foundation. But there's a lot of other ones. It'd be great. So it looked great. The data is great. It's definitely going to have a high, like, efficacious level of people being able to not use for long periods of time, and we know that can be the start of a massive improvement in their well-being. So can't recommend it highly enough.
Thank you. Yeah, I appreciate that so much. And yeah, it is the one kind of evidence-based treatment at this point. And it's been such a challenge for so many folks who are curious about it, interested to really implement, especially in kind of other clinical settings.
Yeah.
And I do wonder, like, in terms of setting this up, so it sounds like space was maybe an issue, some of the way that this is funded is an issue. Are there any other hurdles that you faced and approaches that you took to overcome?
So one of the things is like you have to kind of qualify, you know, so there's like you have to go to some mandatory trainings, and then you have to pass like your the person who's the intervention specialist has to pass like a sort of a quiz or a test or something to make sure that they retain that. And then there's just some things around the way that incentives are I mean, there's limitations on those, and you can't really get around it. Like, so that there'll be like gift cards that can't be used for like alcohol or something, things like that, you know. And that's annoying because it's quite limited on which vendors take those, and so clients, some clients were having like a little bit of a problem there, and but it's not like we can't choose that. That's coming from the funder. So that'd be that's something for advocacy. I think that what else would be yeah, definitely the privacy thing, and then the sort of fiscal, you know, making sure that that's regulated. There's certain kind of obligations in the way that you report clients, and the gifts that you give away, like, you know, the number, the volume, and the cash amount of the incentives. So there may be some restrictions on that. Or just reporting, you know, like requirements. But it's, I think if you've got this, I think the space would be, that's like a, you know, you must have a private space, you know, like with, you know, like your HIPAA, you know, two steps removed for locked up confidentiality. So I think some, you know, some of our less funded SSPs would struggle, but the ones that have got brick and mortar can definitely do it. There's probably a list of the criteria, you know, if I can find it, I'll send it to Matt or something, and he can share it with the group.
Yeah, absolutely. Thank you so much. Anybody else have experiences with implementing contingency management or any of these other topics that we've discussed? Maybe other kind of behavioral interventions, or aside from that, just strategies for reaching so many folks, or you know, providing peer-delivered services. Or if we're missing something here and you're like, hey, you're not talking about this other really important thing, we would love to know that as well. All right. Lori has added, our peer-led services have been very successful. The stories we hear from our communities are heartwarming. Example, folks have told us they feel productive and feel heard and seen. The level of relationship building is rich, the humanist piece. Yeah. Lori, take it away.
Yes, I would just say that just the stories that we're hearing when people are coming in and helping out, and just the part that they say, you know, they feel part of this community and part of the services, and they're proud. Like they just are super proud that they're able to help out, and like, you know, oh, I work with face to face, and you know, I'm doing this, and it's just really awesome to get their perspective on what is needed, and how we're able to make that happen. And so yeah, it's great. It's great, and it's totally going towards the nothing for us without us motto. And I mean, I feel like I've known that with harm reduction for a very long time, but the upper leadership now is like, oh my gosh, this is awesome. We should have been doing this. So just appreciative for that.
Yeah, that's a really excellent point. How did upper leadership become interested in this? Like, did you kind of present something to them? Like, how did that work?
Yeah. So there was just well, first we had some leadership changes. That was one. And then we had some new members in our board of directors. And so presenting the information around bringing people in, there was some stigma within staffing that was like, we don't want people inside these certain spaces helping us, because what if they, steal? What if they do this? What if they do that? And it's like, wait a minute, we're helping these people, we're working with these people, we have to have some trust in them. And so like it was really a matter of just doing it and then saying, I told you so, this is how easy it works, and it's just it was some internal stigma that was happening that we worked a lot on. And then again, like I said, we had upper management changes, and our new executive director, who has been with us for a few years, she's always been on board of real harm reduction. I mean, she lived in the Netherlands for a while, and yeah, she's just great. So she's just like, go for it, go for it, go for it. And yeah, it's awesome.
Thank you. And I'm really curious, when you say real harm reduction, because I think we hear a lot of, in different settings, different interpretations of what harm reduction truly means. When you say real harm reduction, what does that look like from your perspective?
Yeah. So for us, that's just doing what we say and say what we're doing, and not just putting it into words, but actually in action. And so, showing up for people, being consistent, really meeting people where they are. That term, meeting people where they are, can be taken in so many ways, and we don't have boundaries around that, meeting people where they are. We whatever needs to happen, we'll try to make happen that's realistic within what we can do, and always thinking in that lens of reducing harm to people, and that opens it up so much, to be able to better serve our community, who is less underserved, and primarily are reaching our communities of color here. It was really difficult, but providing these peer-led services, folks, they'll trickle in, and then they're like, okay, and then the word will spread. They're cool. They're not, they're not going to do this. They're not going to do that. Go help and see. And then the word just starts to spread like wildfire. Shouldn't say that, especially in Sonoma County, but it's just a positive thing.
Mm-hmm. Sorry, I'm just writing this down. Yeah, I think that true kind of word of mouth is irreplaceable in so many ways.
And folks just are proud of being part of the organization, our peers.
Mm-hmm.
They're proud of that. And we can see like transformation with some of our folks, as far as like, either reducing their use, or just coming in more presentable. Things like that are uplifting to folks' self-esteem and that type of thing. And so it's just really, really, really nice to see lots of different ways that it's benefiting.
Mm-hmm. Thank you so much. I think kind of what we were thinking was certainly like the harm reduction philosophy is, really what's working. Being compassionate, being non-stigmatizing, and like genuinely like not only philosophically meeting people where they're at, but also like going out and meeting people where they're at, is really, really important. Matt, funny how dignified, non-exploitative work and housing and social space has that effect. Yeah, I know it's shouldn't be a surprise. Any other thoughts folks want to share? This is really, really helpful. And again, this is stuff that I think we will potentially reach out and want to talk about a little bit more in depth as well, but certainly stuff that we want to share with DHCS about this program. Ah, good point, Matt. Is there anyone on who can reflect on doing this work in rural spaces? If you want to raise your hand, if you want to type something in the chat. I'm also totally happy to just kind of chill here if anybody has anything that they want to add. And I'm quickly just going to share my email address as well as Kira's. If you have anything you want to reach out to us about, if you have questions about anything we talked about, or you think of something that you'd really like to share, definitely feel free to contact us at any time. Sorry, meant to leave that up. But yeah, that's kind of the end of our presentation. We really wanted to leave most of the time for discussion. So again, if anybody has to go, I think we're pretty close to wrapping it up here. I see Joe just added MCABHN, which I'm not totally sure what that stands for, but maybe we can ask you in one moment, is very rural, and our team covers about 3,800 square miles. Wow. We are staff with lived experience and utilize community partners to support with engagement. Awesome. Joe, I see you popped up in the screen. Did you have something to add?
Yeah, I mean, can you hear me okay?
Yes, thank you.
All right, yeah. So one of the things we do is, we definitely try to have community events, and we try to be at as many as possible to help break the stigma behind what harm reduction really is. We're in a fairly conservative area that doesn't quite understand harm reduction approaches, because they don't know what they don't know. But we do our best to try to educate not only the community, but our participants as well in safe practices. But I think the key ingredient to what supports our ability to do the work we do is our staff that has lived experience in our true to heart harm reduction approach, and walking that gray line to meet the needs of our participants, and support them with the growth that they want to make in their recovery, or while they're in medicated assisted treatment.
Mm-hmm. Thank you, and I'm furiously writing. Could you talk a little bit more about supporting the growth that they want to make? Because I think that's sometimes something that people who hear about harm reduction kind of miss.
So yeah, we're all about meeting individuals where they are at on their journey, and providing whatever information they're seeking to them so that they can make healthy choices, as well as us trying to provide healthier ways for them to live. But really what we do is primarily support their decision-making process, and support them building self-efficacy towards the direction they want to go, whether that's making healthier choices, or medicated assisted treatment, and or abstinence, if that's what they choose to do. Yeah.
Thank you. Really appreciate that focus on self-efficacy. Oh, thank you. Mendocino County. Okay, great. I see Jack has asked where we can get access to the presentation slides. I believe the center will be sending them out afterwards.
Yeah, thanks, Kendall. We'll send those out along with the recording once we have that processed and ready to everybody that registered for this webinar. And we are happy to hang out a little longer if folks have other questions or comments they want to add in, or if you need to drop off too, we totally understand and just appreciate your time joining today.
Thank you all so, so much. Again, we're, as the data team, really excited about this project and really, really grateful for all of the work that you do. And just appreciate all of the insights that you've shared with us already, and your time for being here. Thank you.
And thanks, Joanna. We see your comment. You'd like more of these information gatherings. Love that idea. And we'll be thinking about how we can do more of that in the future.
Hey everybody, this is Matt from Sierra Harm Reduction Coalition. From Sierra Health Foundation. I've got those guys on my mind lately. Just kind of as we're wrapping up, I do want to really encourage people to think about using these data in both sort of like local support for your organizations individually, but also collectively. This like getting people clinical services and treatment is obviously not the main point of harm reduction or even the point of harm reduction, but it is compelling to a lot of other folks. Like we know that that's how, the original Cheery funding, back in 2018, 2019, partly got sold to the legislature was, this notion that this was an avenue for connecting with out of care folks and doing treatment navigation and stuff like that. This, more recently, the expanded funding came with this recognition of the role of harm reduction services as like backbone of naloxone access and the OEMD services. So, I think this data brief is super useful. It just has some really striking, points that it makes. And I think we can also lift it up more. Like all of you, we've been hearing some really good stories on the call today. I think that kind of narrative storytelling piece of this is really important because, stats and stuff get you a little bit of the ways, but putting, skin and bones on that often makes the case a lot better. And we also have other kinds of data that are directly relevant to this. So stuff that, it was done in the earlier version of Cheery through the point in time surveys, some of that directly gets at this. There was one set of point in time surveys a year apart that looked at before this project started and then a year after it had started, looking at participants' reports of access to medication for opioid use disorder. So I think, opportunities to like combine some of that stuff up are going to be important. And I partly say that because I'm firstly thinking about, the overall cut that happened, the reduction in funding that happened to COPRI before we even got started, because the CDPH's share of opioid settlement funds got reduced. And then also because COPRI is, again, a one-time appropriation that ends in 2027 instead of continuing forever at a higher level, which is what we should be doing in California as a place that was rightly an early adopter of syringe access and other harm reduction services. And it's, we're kind of last time for finally baking this into state policy and funding streams forever and ever.
I think we may have lost Matt mid-sentence.
Oh no, I was just done.
Oh, you were done. I'm sorry.
My
I'm
bad.
sorry. I think
Um,
I missed the last little bit of what you said,
I'll
maybe.
conclude by saying I'd love to help. And like those of us working on harm reduction at Sierra Health Foundation would love to help, um, you know, tell that story in service of, policy and funding that supports programs long into the future.
Yeah, and that's definitely something we are super interested in as well. If anybody wants to see maybe further breakdowns of these data or just help interpreting data at any point, we are so here for that. Please email us anytime, seriously. And yeah, any way that we can be of service from the data perspective, feel free to call on us.
Well, thank you both so much. And just a couple of final points to offer. I know we'll be talking more here at the center about how we might share out and disseminate this brief more widely. So stay tuned for that in the coming months. We'll also thinking about, really storytelling and telling your story. We're going to be offering in May a series of 3 workshops on storytelling, running over consecutive weeks from early to mid-May. So be looking for that. We hope you'll join us for that. And just want to say thank you so much to Kendall today for leading this webinar and presenting this amazing work. We really appreciate your partnership. And just thanks to everyone for joining us today and your thoughtful comments.
Thank you, everybody.
All right. With that, we'll close out. Have a great day, everyone.